Hi, this is Dr. Alex Chen with the Baltimore County Department of Health, bringing you a brief update on syphilis. So this is an update on recent trends with a little bit of a self-assessment, but it's not meant to be a comprehensive review. So we'll dive right in with some bad news. These are some graphs from the CDC. You can see that cases of syphilis started rising sharply around 2017 and continued to rise into 2020 despite incomplete reporting and testing due to the pandemic. We don't have data from 2021 yet. Most of the cases are in young men. We'll explore that a little bit further in the next slide. So this is on the right side, the male-female breakdown. You can see the vast majority are in men. As I mentioned on the previous slide, most of these are in the younger age groups. In the racial categories, most of them are among Black men as the largest group, followed by white men, Black women, and then Hispanic or Latino men. This is a graph on congenital syphilis nationwide. Again, you can see cases started rising towards the end of the last decade. The trend in Maryland is a little less clear since it's a smaller number overall, but cases also have been rising here for the past few years. Here's some photos of syphilis presentations. I'm not going to cover all the stages and possible manifestations, but this slide is a good reminder that syphilis remains a great imitator. On the upper left, you can see a lesion on the tongue. Now, if most of us saw a genital lesion, hopefully we would all have syphilis on the differential. However, you should remember that the primary sort can appear on any mucous membrane, whether it's in the oral cavity, on the genitalia, or even inside the vagina or anus. And so it may be very difficult to spot. On the bottom right is the plantar surface showing signs of secondary syphilis. It can be either localized as shown, or it can be the rash can be generalized, and it can be quite subtle. On this slide, we have some more pictures from the CDC website. The upper left are bullous lesions on a newborn infant. The bottom left is epiphysitis, again in a newborn infant, and on the right side is a neonate with jaundice and hepatosplenomegaly. All right, hopefully you're ready for some questions. Don't worry, these are not being graded. If you'd like, you feel free to pause the slideshow if you need some more time to look over the options. These are based on some questions that we've received in the past. So scenario one, you're prescribing PrEP for a man who has sex with other men. So how often should you test for sexually transmitted infections? Is it monthly, every 3 months, yearly, or when symptomatic? I'll give you a few more seconds to look that over. Okay, and the answer is every 3 months in this situation. So for the highest risk patients, which are MSM with multiple partners, you should be testing every 3 months for HIV, syphilis, gonorrhea, and chlamydia. Lower risk groups can be tested less frequently. So MSM who have just a single partner should still get tested at least every 6 months. And the lowest risk group would be heterosexuals in monogamous HIV discordant relationships, and they should still get tested at least yearly just to be on the safe side. And that is from the CDC guidelines on PrEP. Okay, continuing on with the same scenario. So which test would you is the best test for syphilis in this patient? Would you use an RPR, a VDRL, one of the antitreponemal tests such as the EIA, or would the test vary depending on the scenario. Okay, and we'll show the answer now. And this is a bit of a trick question. It does depend on the patient. So most lab tests you probably are familiar with now use what we call the reverse algorithm. And that starts with usually the enzyme immunoassay or the EIA, which is a specific anti-treponemal test. It is less expensive and more accurate, more specific and also probably more sensitive than the RPR in most cases. So if the initial test is positive, then you should reflex that to an RPR to determine whether or not this is whether or not this patient needs further testing or treatment. So in many of the commercial labs, you'll be able to order either what's called a syphilis cascade or the EIA with reflex to RPR. Um, Patients who previously had syphilis will usually remain positive on their EIA or other specific tests for most of their lifetime or their whole lifetime. And these people should then start with an RPR with reflex to titer, since you're going to get a positive test from the other test from the EIA anyway. So um, oftentimes we get questions about people who were not sure about whether or not they were treated. Um, So if you don't have the records, please go ahead and give us a call or give your local health department a call or wherever the patient was treated in the past, and we can usually pull those records up. Okay, a different scenario now. So you have a patient with memory loss and um, the patient has a positive syphilis test. And so in this case, the EIA is positive, but the RPR is negative. Patient is widowed, is not sexually active now, and denies having a history of syphilis. And in this case, you have no old records, and the local health department doesn't have any either. So what should you do? Should you go ahead and treat for neurosyphilis based on the memory loss? Should you do a lumbar puncture? And um, if that's negative, then you treat for secondary syphilis. Should you order what's called a TPPA? That is a um, particle agglutination test for Treponema pallidum, or should you do no further testing? Okay, and so in this case, you would get the TPPA, or the particle agglutination test. So as always, no single test is perfect. There are multiple possible explanations for this scenario. So the person could have a false positive test, which is unusual, but could happen. The patient could have previously had syphilis, and that could either be treated, which would explain why the RPR reverted to negative, or after many years, the RPR can revert to negative on its own. And the other possibility is that the patient could have just become infected and be in the window period when the EIA is positive and the RPR is negative. So basically you get a third test, which is a tiebreaker, and that will help you determine what to do next. Okay, moving on. All right, scenario 3. Patient presents with a painless genital ulcer for the last several days. So you go ahead and draw blood tests and obtain your urine testing. So you test for HIV, syphilis, gonorrhea, chlamydia, and given the current scenario, given situation, you should consider monkeypox also because there are some people who don't seem to have a lot of pain. Even though most people do have, if it is a genital lesion, most of these people will have very tender areas there. Uh, but what should you go ahead and what should you do now while you're waiting for your test? So should you wait for the test results before treating for syphilis, or should you treat empirically on the same day? Okay, so hopefully most of you went ahead and treated the patient that day before he or she left the clinic. So the definitive test has been dark field microscopy, which most of you will not do. It's just not available to most people at this point. PCR testing is also definitive, but also not widely available. So if you do obtain the blood test, remember there is a window period, like I mentioned on the last slide, where the EIA is positive and the RPIR or VDRL may not be positive yet. And so that may cause confusion. So in this case, go ahead and treat that patient. It also prevents that patient from, or it reduces the amount of likelihood that that patient goes on to infect somebody else. Also, I should just mention there are a few other cases or few other causes of painless genital lesions. This is a little bit outside the realm of this talk. So if you are in doubt, go ahead and make sure you look those up so you can rule those out. Okay, moving on with the same patient. So the patient says he traveled domestically. I should just clarify, he's not out of the country. So he traveled within the United States. For work and had intercourse while he was on this work trip. Um, his spouse has no symptoms. He thinks he acquired this infection about 3 weeks ago. So what is the next step for the spouse? I should specify. So should you see the spouse and draw labs and treat immediately, or should you obtain the labs and wait to get the results before you treat the spouse? Okay, again, don't wait for the test results. In this case, the spouse or partner should be treated immediately. There is a scenario where you might draw labs and then wait for the results, but that's only if you're sure the spouse will return for treatment and the spouse and the exposure was more than 90 days ago. Okay, so you've decided to treat both the patient and the spouse. So what's the correct form of penicillin to give in this situation for primary syphilis or for secondary syphilis? Is it penicillin G procaine? Is it benzathine and procaine penicillin or bicillin CR? Or is it benzathine penicillin or bicillin LA? Or do you just look it up to be sure? And in this case, I'll take either C or D. So the correct answer is bicillin LA, which is the long-acting penicillin. But if you want to be sure and look it up, I have nothing against that. There have been plenty of reports of clinics giving the incorrect form of bicillin because the names are very confusing. So again, I'm always in favor of looking things up. And also as a reminder, for neurosyphilis, including ocular or otic syphilis, you will need to give IV penicillin rather than the IM injection. Okay, so assuming you are all practicing in Maryland, when should you test a pregnant woman for syphilis? Is it at the first visit? Is it during the third trimester, at delivery, or all of the above? And this is a change in the last few years. It is all the above. So in the past, testing at delivery was only required in high prevalence areas. So A and B would have been correct, but now MDH has defined the entire state as a high prevalence area. So you should be testing at all 3 points of care here. Okay, and I'm sure you're all happy that this is the last question. So neurosyphilis, does it occur only during tertiary syphilis, or does it only occur more than 10 years after the initial infection, or can it occur at any stage of syphilis? And yes, neurosyphilis, ocular and otic syphilis can occur even in the initial stages of syphilis. So key points from today's talk. So syphilis rates, including congenital syphilis, are increasing in the local area and across the United States. Enhanced screening of pregnant women and high-risk populations is key to reducing the spread, and partner treatment should not be delayed. If you have questions, please call our partner services branch. They're available at 410-887-2437 or 410-887-AIDS and ask to speak to one of our disease intervention specialists. These are people trained specifically to deal with sexually transmitted infections. This is their bread and butter, and they'd be happy to help you. Thanks for your attention today.